Okay, so I'm Patricia, and I'll be speaking with you about psychological interventions. Okay, firstly, actually, I want to thank two of my colleagues who helped me. I was tasked to do the portion on psychological interventions, but also for suicide. So I had my two colleagues, Mr. Goh Zheng Qing, who helped me with regards to the literature review. He second pair of eyes to look through and find articles was very important because I could have missed some of them. And also Tina Tin, another of my psychologist colleagues, who helped out with regards to the review itself, the initial review that then formed the evidence tables. Okay, I'd like to start off with something that's actually not really in the CPG, but basically just to give us an idea of the basic aims of therapy when we're doing bipolar disorder. Actually, historically, psychotherapy was not considered, or psychological interventions were not really considered as the bread and butter of bipolar disorder treatment, and it was pharmacotherapy that was very much like the mainstay. I would still say that it's the mainstay, pharmacology. I always get stuck with this part, but the medication part of it, yeah, is still the mainstay. But more and more, psychotherapies are a very important part of the treatment because it's not just about the biological part, but about all the other aspects of people. So the main aims of therapy then would be to alleviate the acute symptoms, and this would be especially for depression. Because from my own experience also, it's very difficult going in when someone is manic to do anything with them in terms of talking with them, that kind of thing. It's very, very difficult. So, but when people are depressed, it is easier to talk with them. Yeah. So I do agree with this. And also to restore psychosocial functioning after the acute state and to prevent relapse. So for psychological interventions, they're very important, especially for the maintenance part. Yeah. So this is basically what you have in your CPG, the summary of all the psychological interventions possible. Okay, so thinking about it, there are some psychological interventions that can be provided on a larger scale. And I'm thinking of the ones that I'm going to talk about today. These two might be something that you might also consider using as part of your, whenever you interact with patients, it will be much more possible. The first one is psychoeducation. The second one is early warning signs intervention. Okay? Of course, all these interventions that in the CPG are considered the evidence-based. Yeah. So for psychoeducation, what is that? And okay, for the CPG, we consider it as a general practice guideline that whenever possible, health professionals should provide psychoeducation to patients with bipolar disorder, and as well as their families and caregivers, because families and caregivers are oftentimes quite at a loss what to do, and so if we can psychoeducate them as well, they can be helpful, especially when the patients maybe are not able to help themselves. And for early warning signs, okay, this, okay, wait, hang on. To go back to this slide on psychoeducation, I think this is something that you can do as a doctor, as a first point of contact, but then don't forget other health professionals that can do it. Yeah. It can be your nurses who often provide psychoeducation to patients, and it can be other professionals as well. If you may have social workers in your multidisciplinary team, they can do it. Actually, practically anybody who is a health professional can do that, yeah, provided they have the training and they know what are the information to provide in the psychoeducation. For early warning signs, this is a grade A and level 1A recommendation because it's based on a very solid evidence. And for this recommendation, we think that upon identification of any early warning signs or relapse signatures, because we find that for individuals, they all differ in terms of what indicates relapse for one person versus another person. So maybe for one person, if you find that, if they find that they are very talkative, that may indicate a relapse. More talkative than usual, that may indicate relapse. But for another person, it's not that. For another person, it may be when they're very grumpy, let's say. Yeah. Okay. So everyone is a little bit different. Okay. And then when you identify the early warning signs or the relapse signatures, either the individual or the family members can identify it. Okay. The individuals can then use the plan of action that they develop together with you based on the early warning signs. Okay. So you might ask, what are some of the early warning signs? The common ones. Oh, hang on. Sorry, I thought I had a slide for this. Okay. I don't have a slide for it, but it's in your CPG. Okay. There are some very common mania prodromes. I'll read them out to you. Number 1, being more sociable. Number 2, increased self-worth. Number 3, racing thoughts. Number 4, increased optimism. 5, irritability. 6, increased activities. 7, decreased need for sleep. And lastly, sharper senses. I wish I had thought of putting them into acronyms, after seeing bullying slides. Yeah, but those are the mania prodromes, the common ones, and they're in your CPG, so not to worry about that. And then there's some very common depression prodromes, like loss of interest in activities or people, not being able to put worries aside, feeling sad, wanting to cry, and interrupted sleep. Yeah. So these are some common ones. I'll give you an example of when I did this. Okay, I had one patient. This is a lady patient, and she mostly was able to get the relapse signature for depression because she had depression much more than mania. All her episodes were depression except for one. So she had quite a good idea of when she would relapse into depression, and a little bit of an idea of mania. So for her depression relapse signature, one of the key things that would happen is that she knew that if her sleep was interrupted, the last common depression prodrome is interrupted sleep. She knew that if she didn't get enough sleep, that kind of thing, she would start feeling loss of interest in activities. She was a churchgoer, so she would start losing interest in going to church. And this is a lady who goes to church every single day, So she knew that if she found that this was happening to her, that it would be a problem. Yeah. So what we discussed was if she were to notice this in herself or her husband, because she discussed this plan of action with her husband as well, or if her husband were to notice that, he would alert her, and then she would make sure she would try to do something different. So plan of action was get more sleep, yeah. Make sure that, if she has a lot of activities on, that she lowers down the amount of activities. And then if she doesn't feel like going to church, then she had a very nice sister-in-law who also went to church every day, yeah. Then she would inform this sister-in-law, and then this sister-in-law would encourage her, come, you come with me. She would usually go alone lah. But if she felt that way, then her sister-in-law would be, encouraged, would be informed about it, and then her sister-in-law would encourage her to come along. Yeah. Okay. And then with regards to her mania prodromes, she had less of an idea, but from that one time when she had mania, she thought that probably it would be when she became more sociable, because she's more like an introverted sort of person. So if suddenly she decided to, be very sociable and talk with a lot of people and become very talkative, right? Then she was like, oh, yeah, I think I'm going to get manic soon, yeah. So this was quite helpful for her with a lot of the depressions, but there was one time when it was really very bad and she just couldn't do it. No matter what she did for the early warning signs, she couldn't stop the relapse of depression. So this is when other things had to kick in, the medication, etc. Yeah. Okay, then these three psychological interventions, they need to be conducted by those with specialized training. Yeah, so I will try to go more quickly over these ones. So there are three: CBT, family therapy, and interpersonal social rhythms therapy. There was a study done by Milkowitz and his colleagues in 2007, and patients received intensive psychotherapy, either of these three kinds, okay, of up to 30 sessions, okay. So that's like quite a lot, right? The mean number of sessions was 14.3. So either they got what's called family-focused therapy, or they got interpersonal and social rhythms therapy, or they got CBT, cognitive behavior therapy. So what they found when they compared these three groups to a group in collaborative care, which was a brief psychoeducational intervention, okay, and that one was very brief. It was up to 5 sessions. Mean number of sessions was 2.2. Okay, they found that the people in these three psychotherapies group, they did better than the ones in the collaborative care. Actually, it's not so surprising, right? Because I mean, like 14.3 sessions, mean number of 14.3 sessions versus 2.2 sessions. You would expect that, right? And then between the three psychotherapies, there was no difference, no statistical difference between those three. Yeah. And of course, the psychotherapies were much less cost-effective than the brief intervention. And the brief psychotherapy actually also had a good 1-year recovery, 51.5%, although it was considered significantly less than those in the intensive psychotherapy, which was 64.4%. Yeah. But something to consider that maybe in our, in our resource scarce kind of environment, we might then consider doing psychoeducation on a much broader scale than intensive psychotherapies, which will then have to be done by people trained in either CBT or family therapy or interpersonal social rhythm therapy. Okay, for CBT, CBT aims to change people's way of thinking as well as their behavior in order to improve emotional states. I suppose that's why they call it CBT. C for the cognitive, B for the behavioral, and we're trying to change people's thinking as well as the behavior so that they can feel better, basically. So when I do this, because I'm trained in CBT, when I do this, then I would try to help people learn strategies to improve their moods when the moods are low and to reduce the highs when they're manic so that they can keep their mood within a previously agreed range. Yeah. So if let's say -5 is you're at the most depressed and 5 is you're at the most manic, then we agree. Maybe something like -1 to 1 would be your agreed range. So back to that patient that I saw, I would ask her each time she comes, so where do you think your mood is now within that range that we are talking about? Yeah. So she went with -1 to 1. But then most of my patients actually prefer to be at slightly manic. Yeah. So like most of them might go for 0 to +2. Yeah. So then I will ask them, okay, at +2, how are you like? Does it disrupt your functioning? And if they say no, I can still function, I can still be a mom, I can still go to work and everything is still quite okay, like they're just a little bit hypomanic, then okay, all right, as long as it doesn't disrupt your functioning. Okay, so for family therapy, because family functioning can maintain the person's psychological balance, that's why we would look into family interventions. Yeah, because a lot of times, of course, people may actually disrupt their families quite a bit. So here I'm thinking of my master's thesis on family harmony, and one of the families that I interviewed, there was a person with bipolar disorder in the family, and the mom was especially very concerned about him. She was already a concerned mother because he was the only boy. So the significance was a lot, especially since this was quite a traditional Chinese family. And then he has bipolar disorder, so she became even more protective, and that set up a certain dynamic that was less healthy. Yeah, so they actually went for family therapy, and the therapist noticed that in the family, his interactions with his father, who was more accepting of the bipolar illness, as opposed to the mother, the interactions with the father were more harmonious. So the family therapist suggested, why not, whenever he has an episode, let father take over the care. Of course, mother is the main one to look after him all the time, but during those times when he is having a severe episode, then let father take over for a while, temporarily. So that works better, yeah? Okay, so family therapy for bipolar disorder tends to be either family psychoeducation or behavioral family therapy, where they discuss things like communication and how to communicate in a positive way and things like that, as well as systemic family therapy. So, you know, what I described just now, that would fall under more systemic family therapy, where that therapist was trying to look at the way the family system worked and trying to make a suggestion that would be working at a systemic level, where, say, father takes over rather than mother. Okay, then there's interpersonal social rhythm therapy. Okay, it stems from interpersonal therapy, which is based on these 4 interpersonal problem areas. Okay, and then with IPSRT, they added in the fact that for people with bipolar disorder, they are very vulnerable to sleep-wake cycle difficulties. So, like my patient I was telling you about before, once her sleep was affected, you know, then it became very difficult for her. It was in fact one of her, it was in her relapse signature. So in this treatment, they combine interpersonal therapy with the sleep-wake cycle vulnerabilities so that they help the people, their patients, right, better manage the chaos of bipolar disorder, just improve their overall functioning. But for this one, I must say very honestly that I'm not trained in this, so I don't feel that I'm the best person to talk about it. But for family therapy and CBT, okay, you know, yeah. Okay, so that again is basically the summary, yeah, and that's it. Thank you.